So, good afternoon, uh, participants. As I await the joining of the participants, greetings on the occasion of World Stroke Day from Bharati Hospital Research Center, Bharati Vidyapeeth. So, on the occasion of World Stroke Day, I propose to revise uh, the stroke, ischemic stroke, especially the management and the recent developments and the campaign by World Stroke Organization and what is the stroke management in COVID pandemic especially. So with these things in mind, define the stroke as a stroke occurs when blood flow to the brain is interrupted by a blocked or burst blood vessel. When the brain is deprived of blood flow, neurons die within minutes. So, and the strokes are hemorrhagic stroke, which is about 17%. That is blood all around the brain or inside the brain. That is subarachnoid hemorrhage or intracerebral hemorrhage. And the ischemic stroke is a major chunk, almost 83%. And you have large artery occlusions, cardioembolic strokes, today's talk will be mainly on ischemic stroke. As you all know, it is the most frequent major neurological disease, 15 million per year, and second commonest cause of death worldwide. It has higher mortality than most forms of cancer. The leading cause of long-term disability, early recognition and diagnosis are key to the recovery of the patient. That's very important. And it's a medical emergency, that everybody agrees on that. That's a medical emergency. And there is some area of the brain which is permanently damaged, that is called infarct, and around that area there is an area of brain which is deprived of blood in optimal quantities, that is ischemic penumbra, and this area is going to be damaged permanently if we don't rescue with the available interventions. The brain damage, once it occurs, is permanent and irreversible. So all the recent developments are targeted to salvage this ischemic penumbra. And stroke, as you know, has got high morbidity and mortality. So we need to act fast and quickly and efficiently. So the slogan "Act Fast" has come up for the stroke management and recognition. If you look at the outcome of the first ever stroke, most of them are, I mean, whoever has to die, they die within 1 month, but half of them die within 6 months. Those who suffer from stroke, only 1/4 live independently at home. The remaining 1/4 and half of them, they are living at home but they require help, and another 12.5% they live in long-term care institutions. So this is a very devastating occurrence or illness. So if you look at your joys, your sorrows, your sense of personal identity and free will, they are in fact no more than behavior of a vast assembly of nerve cells and their associated molecules. So this is said by Francis Crick, and after their famous discovery. So the essence is neural cells or neurons are in fact very important, and these nerve cells are required for your joys and your sorrows. So that's very important. The key physiology of cerebral neurons is that uh, they are fully dependent on oxygen. Okay, I'm sorry, I didn't enable. All right. They are fully dependent on cerebral blood flow, these neurons. There's a constant supply of oxygen and glucose is required through blood, and the perfusion pressure should be optimal. So there are few physiological concepts which we can revise, that cerebral neurons are fully dependent on cerebral blood flow. And like, if you look at the next, what are the requirements? The requirements are cerebral blood flow is usually 45 to 50 ml per 100 grams per minute, and if this blood flow becomes less than 18 ml, then physiological electrical function of the cells begins to fall. You look at the other parameter, which is called cerebral perfusion pressure, which is mean arterial pressure minus intracranial pressure, which is about normal 80 millimeters of mercury. And if this drops below 50, then ischemia and reduced electrical activity sets in. So important equation is mean arterial pressure minus intracranial pressure. Now look at the demand of oxygen and glucose by the brain. The oxygen consumption is about 3.5 ml per 100 grams per minute. That means the whole stores of oxygen that are present in the blood are consumed within 10 seconds if the vessel is blocked and that particular area is deprived, hypoxic, it becomes hypoxic. Similarly, glucose is about 5 milligrams per 100 grams per minute. That is the requirement of glucose or utilization of glucose by brain. And if that store lasts only for 2 minutes, and if the occlusion extends beyond that area, that then they are deprived of glucose and oxygen. Now, so there are etiological factors. Cardioembolic stroke, which is almost about 20 to 30%. That means emboli will lodge from heart and they migrate cranial and develop. There may be some stenosis in the carotid vessels. These are large vessels, and this stenotic segment can be occluded by thrombus and cause ischemic stroke. Otherwise, they may reduce flow, and that is carotid stenosis that gives rise to chronic ischemic demyelination. The essence to understand here is the estimated pace of neural circuitry loss in typical large vessel supratentorial acute ischemic stroke. In the brain, the frontal lobes are the lobes which are very important for human beings, and every minute if stroke is untreated, the average patient loses about 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of axonal fibers. So each hour in which treatment fails to occur, the brain loses as many neurons as it does in almost 3.6 years of normal aging, and so the individual ages very fast. So per stroke, if you look at 1.2 billion neurons are lost, 8.3 trillion synapses are lost, 7140 kilometers or myelinated fibers are lost, and individual ages by 36 years. That is a devastating effect which, with our developments, with the recent developments, we can intervene and prevent. So it all started, the story started in NINDS trial in 1996 when we started giving intravenous thrombolytic therapy. PROACT 2 trial has extended that to intra-arterial thrombolytic therapy up to 6 hours time, and the recent mechanical thrombectomy trials have prolonged it up to 24 hours also. In anterior circulation, the posterior circulation, there are more liberties are taken apart from. So now you know that phrase time is brain, and it emphasizes that human nervous tissue is rapidly and irretrievably lost as stroke progresses, and the therapeutic intervention should be emergently pursued. This general call to action in acute stroke care was adapted from its predecessor in acute coronary care, that is cardiologist, from time is muscle. We were doing MD, that is the catch point, time is muscle, and both tracing their lineage to an aphorism by Benjamin Franklin that time is money, which is very well known amongst card players. So if you look at the fewer deaths and less disability and symptom to needle time of thrombolytic therapy, and this is stroke 150, 130 to 150, and this is acute myocardial infarction, which is about 70 to 60. That means as the symptoms the hours prolong, there are large number of cases of stroke can be reverted, but not as many in MI. But the myocardial infarction treatment has been very well popularized by cardiologists, unlike the stroke. That's why this awareness program, and October 29th is called the World Stroke Day, and that's when we remember that we have to make everybody aware. So it all started a long time back. I'll just quote only four. World Stroke Day of 2016 said it focused on raising awareness that stroke is treatable, and that with fast recognition and access to specialist stroke care, people can not only survive but recover from stroke. So awareness, access, action. This is the fact. Face the facts. Stroke is treatable. That is 2016 slogan. In 17, what's your reason for preventing stroke? That means World Stroke Day of 2017 campaign was focused on stroke prevention. Then the stroke prevention, the major risk factors of diabetes, hypertension, cigarette smoking, and hypercholesterolemia, how to detect them, how to treat them, that has become the World Stroke Day 2017 slogan. And in 18 slogan is focused on life after stroke. We wanted to salute the 80 million stroke survivors living around the world and raise awareness just what it takes to get up again after stroke. That means though you have stroke, but there is a chance for full recovery provided you get treatment within the time window of 4.5 hours intravenous, 6 hours intra-arterial, mechanical thrombectomy up to 24 hours. World Stroke Day 2019 focused on stroke prevention. Don't be only highlighted the global risk of stroke to 1 in 4. Earlier slogan was 1 in 6. Now it has highlighted that stroke happens 1 in 4 and encouraged people to understand the individual risks and take steps to reduce them. So don't be the 1 in 4, all of us will have a stroke. So that's the slogan. And this year the World Stroke Day slogan is 1 in 4 adults will have a stroke, but being active can help decrease your risk. So you be active, join the movement of being active. And World Stroke Day, what it says is 1 in 4 of us could have a stroke, but being active helps to reduce our risk. That's why we are asking people to join the movement and be a part of the world's biggest dance chain. That means being active means you know in this as a campaign mode, you do some steps of dance and video it, and it's there in Hindi also. Show us your funkiest moves. Put together a dance sequence with 4 dance moves. You can use your own drawn your local dance culture, or use our campaign signature moves to get you going. Video your dance routine on your mobile phone. Share your dance video on social media, tagging 3 friends with this message: I took the World Stroke Campaign Dance Challenge to raise awareness of stroke and prevention. Over to you, A, B, at the rate, and start your dance with my last move. Add 3 of your own and tag 3 friends when you share. So 1 in 4, join the movement, World Stroke Campaign. Keep it going. So that's how you will have to create the awareness of stroke in others. So fast, that is facial weakness, arm weakness, speech difficulty, and time to act fast. This was 1 in 6 when started very old campaign, but now this is 1 in 4 people are suffering stroke. So it's all the more important to act fast, recognize the stroke with the stroke early signs of weakness, numbness or paralysis of the face, of arm or leg, difficulty in speaking or understanding, dizziness and loss of balance, loss of vision, headache, usually severe and abrupt, difficulty in swallowing. All these things For a common man, when you see a patient and recognize, please bring them to hospital for immediate treatment and medical attention. So if you give immediate treatment, the blocked blood vessel, as you can see here, can be opened, supplying glucose and blood to the brain air parenchyma and make it survive what I was talking about, the penumbra. So the drug that is administered is RTPA or Actilase, 0.9 milligrams per kg body weight, 100% as a bolus, rest as an intravenous infusion over 1 hour. And unfortunately, only 1% of the strokes get thrombolytic therapy. That's the reason of this awareness in public programs. There is lack of awareness in public, lack of awareness in doctors, lack of interest in doctors, delayed referrals, the cost is high, a risk taking inability of the doctors. So there are many factors, but we should beat all of them and get implement on thrombolytic therapy program. The net benefit, if you look at, for every 100 patients, 13 more patients will achieve independence at 3 months. It's a very big number. If you look at the whole population of these stroke cases, this NNT is very, very good. So the awareness should be full and patients should be brought within the time. The NNT, if you treat the stroke 3 hours, within 3 hours, 1 in 7 will improve. If in 6 hours, 1 in 11. Between 3 and 6 hours, even then 1 in 25. So there is benefit even if it is delayed. And there are indications, and you can choose depending on the imaging abnormalities. You can always try and treat the patient with thrombolytic therapy. So the SNINTS trial is the one of the initial trials, and this is a standard trial which has brought the Actilase treatment, and then proactive trial. This is occluded artery, and you can put a catheter. This is the occluded artery, and you have put a catheter into this and injected Actilase, and this has opened up. See the MCA and the ACR. See, this is the result of PROACT 2 trial. With that, when these trials results were available, we started giving intra-arterial thrombolytic therapy way back in 2004, and such is 16 years ago. So now lot of developments have come. You can remove the blood clot, that is called mechanical thrombectomy. You can aspirate the clot. So the mechanical thrombectomy or endovascular treatments, EVT as it is known, has come in a big way. So these are the trials which has extended the time window of treatment among Mr. Clean, Escape, Extend, Revascate, Therapy and Pistage. These have extended the intra-arterial time window up to 12 hours and beyond. So this is the development is in 2015 that has changed totally the stroke management. And now we are trying to identify large vessel occlusions at emergency by our critical care doctors or emergency doctors to identify large vessel occlusion, and so immediately they can work up and institute the treatment that is suitable nowadays, that is the state of art mechanical thrombectomy, which yields one of the best or top most results in medical field. The NNT is 2.8. If you give mechanical thrombectomy to 2 or 3 patients, one will definitely improve. So that is the magnitude of this the scale of NNT of mechanical thrombectomy, which is the best in medical field so far. So the time windows and diffusion flare mismatch means a type of imaging abnormality in wake up strokes, and this will help us for people who are developing stroke or diagnosed stroke on waking up in the morning, because the diffusion image abnormality will appear within 20 minutes, but the flare will take up to 6 hours to show abnormality in the damaged area. So this is called diffusion flare mismatch. The diffusion perfusion mismatch, the delineates the penumbra or oligemic brain area, and there is clinical and DWI mismatch, which is the basis for DAWN and diffuse 3 trials, which we will discuss in subsequent sections. So 69-year-old lady with atrial fibrillation, warfarin discontinued due to dysfunctional uterine bleeding, left hemiparesis presented within 2 hours, and CT aspects is 8. It's only in the uppercuts, not right. And CT reconstruction MIP images showed maximal intensity projection images showed clot at the junction of M1 and M2 junction, and this warfarin, this IVTPA started and wheeled into the cath lab, and RT right MCA is blocked, and so you can see that blocked vessel, and mechanical thrombectomy was done, and the vessel was opened, and the last known well is 245 and door to needle is 445, CT 520, groin puncture 615, and complete recanalization 710. So puncture to recanalization less than 60 minutes, and you can see the limited infarcted area on the brain and the vessel that is opened up. So the case says that you should try and open up the vessel and facilitate the recanalization of the vessel as early as possible, so that the cerebral neurons get their quota of glucose and oxygen. So this is the control, and this is the mechanical thrombectomy in various trials. You can see the results are much better with mechanical thrombectomy, which is in the color red here. So effects of COVID-19 on stroke. Now, since March, we are facing COVID-19 SARS-CoV-2 virus pandemic, and the stroke cases never stopped. In fact, if you look at the damage that it has done to the stroke patients, it's immense. Because of the fear of contracting the virus, many stroke cases were left at home. Minor strokes, moderate strokes were not brought to the hospital, and whatever has been brought, they are large vessel occlusions. If you look at the virus devastation, in 19th May there are 4.8 million cases
The
with 3
slides are
lakh
not
deaths.
showing.
In 25th September, 32.4 million cases. By October, it is 43 million cases and 11 lakh 55,000 deaths.
Slides seeing on
So
the
that means there are lot of cases, but the strokes in proportion are relatively less. But still, strokes are seen. They may appear in future, because the survivors of COVID are likely to suffer from procoagulant abnormalities and cause stroke. So we must stick with what we know, but do not speculate. Fact versus fiction. A more measured approach is required to say that everybody can say, stroke is very common, COVID, we see a lot of strokes. But it's not true. We have to really study the pandemic. It is still learning time. It's only 6 to 8 months into the pandemic. We have to learn a lot about stroke and pathophysiology. However, we know a bit about SARS-CoV-2, which is a piece of bad news. That is a single-stranded RNA. It is wrapped in a protein called S protein, and this protein, uh, its complications are because the virus attaches itself to ACE2 receptor, angiotensin converting enzyme receptor. It attaches to that and internalizes into the cell, and mainly in the pulmonary cell, airway cell. So the main organ that is affected is respiratory system, pulmonary system, and neurological illness can be because of critical illness, or it's a coincidental occurrence, or neurological signs and symptoms are being missed in critically ill patients. So neurology can be involved in many mechanisms. So neuropathogenesis, neurological manifestations of coronavirus has been started since August 2020. There are many studies, and this angiotensin converting enzyme receptor distribution was also studied in mice, and it's shown at various places These receptors are present if virus enters the brain through some mechanism. It can latch on to these, and these various cells, neurons, microglia, astrocytes, oligodendrocytes, all are can be affected. And how it happens is cribriform rate. This is the olfactory lobe and cribriform plate, the olfactory nerve, olfactory epithelium.
The slides
Right
are
from
not
beginning,
showing.
it is known that
Hello?
these
Hello?
individuals have anosmia. The smell sensation is affected right from the beginning. So that is one mechanism of virus spread. It also can spread by retrograde fashion in transsynaptic spread along microtubules back to neuronal cell bodies using endocytosis, exocytosis, or fast axonal transport mechanisms. So this is a retrograde spread that is depicted here. So, mechanism of spread across the blood-brain barrier, there are two, what is it called? Angiopathic thrombosis. The infected vascular endothelial cells have been shown to spread SARS-CoV-2 to glial cells in the central nervous system. That's one of the mechanism of the spread. The second one is known as the Trojan horse mechanism. That means infected leukocytes can cross the blood brain barrier to infect the central nervous system. So that's another mechanism which is around. So this is a spike protein and this is a neuron and ACE receptor. That's how neurological manifestations can develop, and all the research activities are centered around the proteins to make the vaccines. So there are many neurological complications described, but the denominator is very huge, and the numerator, the neurological complications are very less, to say the truth. But the disturbance in neurological function happens rather than neurological disease per se. That means neurological dysfunction may be because of hypotension, hypoxia, micro and macrovascular thrombosis, septic encephalopathy, delirium can happen, and immunological mechanism, adaptive autoimmunity, microglial activation, maladaptive cytokine profile. So these are the various mechanisms. So prothrombotic state, direct infection, para or post-infectious involvement of the nervous system. So the neurological manifestations have been thoroughly studied and published. The diseases have been observed in individuals with SARS-CoV-2 infection can be split into three categories based on the presumed underlying mechanism, which I'm going to show in the next slide also. Briefly, they are pulmonary and systemic disease, direct invasion of the nervous system, post-infectious, immune-mediated complications. If you look at the pulmonary and systemic disease, hyperinflammation, multi-organ failure, hypercoagulative state, which will give rise to encephalitis, encephalopathy, and stroke. In direct invasion of the nervous system, vasculitis, stroke, encephalitis, muscular damage, anosmia, and dysgeusia. This is a direct invasion. Yes, yes, yes. Jyoti, yes. What do you want to say? You can type, Jyoti.
Sir, your slides are not seeing there.
Not seen? Oh, oh, I'm so
Not
sorry.
there.
What happened?
First slide only.
One slide only. Slides are not there on screen. So
Yes, sir. No.
what
First
happened?
slide only.
No slide is coming.
No, I message in the chat box, but no slides are seeing there.
Okay, then what I do is I'll just close it and come back again.